Hi, I'm Amrita Sethi, and I'm going to talk to you today about indeterminate biliary strictures, what's new in diagnostics and therapies. I'd like to thank Mary Lee, Phoenix, and Sonia for inviting me to be a part of this great course again. And I'm sorry that I'm not there to join you live, um, but we'll get started. So these are my disclosures. I just wanted to reference the resources that I use and refer to throughout the talk. I highly recommend looking at these at your convenience for further details into guidelines on indeterminate strictures. So first we'll look at etiologies for biliary lesions and strictures. Obviously, we want to distinguish most importantly between malignant and benign. In terms of malignant etiologies, pancreatic cancer and cholangiocarcinoma are the most common that we deal with, although other types of hepatobiliary cancers and even metastatic disease can be causes of strictures. And in benign diseases, we have fibrotic diseases such as chronic pancreatitis or autoimmune pancreatitis, post-surgical with post-chole injuries or liver transplant would be the most common that many people deal with. And then there's other sort of mimickers such as portal biliopathy. There's new COVID-related stricture disease, all of which are important to keep in mind as we evaluate these strictures. It's also important to take a look at the definition and how that's changed, perhaps due to some of the, new imaging and diagnostic modalities that are available. So historically, biliary strictures in the absence of a mass on imaging and those who had previously undergone a standard ERCP and had negative sampling were the only ones that were considered indeterminate. And this made up about 20% of biliary strictures. The updated definitions that you'll find in all guidelines, however, now include strictures of indeterminate etiology from their imaging and history alone, and not necessarily having had to undergone prior diagnostic ERCP. So it does bring to question what do we have available to us now in terms of that evaluation, and how are we changing that with our approach in terms of timing and how aggressive we're being. So we'll discuss EUS, ERCP with various sampling and imaging modalities and enhancement. Cholangioscopy is obviously a very big topic area in this topic to look at. Starting with EUS and tissue sampling, not a lot has changed, but basically we use the EUS to detect small masses and also look and interrogate the bile duct wall, look for extraductal lesions, pancreatic involvement, look for lymph nodes, which we might want to sample, or metastatic lesions. But most importantly, its role is really in F&B. And that too for distal lesions, which we'll discuss in just a moment. These are just some imaging of characteristic findings of, for example, intraductal masses versus more benign autoimmune cholangiopathy, where you have a diffuse thickening of the concentric thickening of the bile duct wall. In terms of diagnostic performance, this is the publication by ASGE in terms of their guidelines, and you can see here that overall it's poor sensitivities, 60 to 70% for either modality alone, but when you add them in combination, this significantly improves the sensitivity of US and ERCP. You will note that even though they weren't able to statistically determine it, there are significantly higher adverse events related to ERCP and certainly that makes sense in terms of the invasiveness of the procedure. And it's interesting that when you do meta-analysis of this, that of all the studies, they actually do favor EUS being performed as first-line therapy, particularly because of the high rates of adverse events associated with ERCP. So there's obviously things that one needs to think about progressing on from EUS to ERCP, like is the patient need biliary decompression, or are they surgical candidates? But the current kind of guidelines and accepted practice is that if it's a distal indeterminate stricture, then EUS and FNA is definitely recommended. Again, considering some of those things about as to whether or not we go into ERCP. And for proximal strictures, we can certainly perform EUS for assessment, but FNA should only be reserved if there is evidence of lymphadenopathy and not for intracellular intrahepatic masses due to theoretical risk of seeding. In terms of ERCP and how it performs with regards to its sampling, there's two main sampling methods that we had traditionally looked at with ERCP, brush cytology and transpapillary fluoroscopic guided biopsies. That same publication looked at the diagnostic performances of both of those alone, and they sort of reflect what we've always known, which is that it's very poor diagnostics with only 40 to 50% sensitivity with either of those modalities. But when you add them in combination, they do increase the sensitivities and specificity together with no significant increase in adverse events. And so all guidelines, society guidelines recommend combination sampling over single modality sampling, whether it's papillary biopsies or directly visualized biopsies. And that takes us to single operator cholangioscopy or cholangioscopy in general, which we'll delve into a little bit more. But the systematic review and meta-analysis also shows that the results favor performing cholangioscopy with ERCP for indeterminate strictures. And even these days, it can be recommended for first-line or index procedure. So let's go into a little bit about cholangioscopy. This has now been well established as a modality. It's a catheter-based visualization system that fits through the ERCP scope. Traditionally, we had one system available to us. Now we have multiple manufacturers creating similar products. They range now in size to help deal with different size or caliber ducts, which can sometimes be an issue when dealing with indeterminate strictures, that there's sort of a normal or a thin distal duct. It allows for good steering to be able to reach lesions, good optics, and of course channels for sampling and other diagnostic modalities as well as therapeutic capabilities. Again, some of the newer cholangioscopes do offer a variety of sizes and some slight differences in visualization as well. For example, here that there may be some enhanced imaging of surface and vascular patterns. We can't forget about direct pearl cholangioscopy, which was sort of even here prior to single operator. This involves directly placing an endoscope into the bile duct. It did mean having access to a special type. The slim scope, which was not readily available, was very fragile. But the advantage here is that it does really give beautiful imaging with some of the enhanced software modalities that we have on our endoscope, such as MBI. So it's not widely available and is really recommended just for select cases and in expert hands. So ultimately, what does cholangioscopy offers us? It gives us visualization of the lesion itself, the ductal epithelium, both in normal and abnormal tissue. It helps us target our biopsies based on those visualized sites and suspicious features. And then it also allows us to perform some enhanced imaging, such as confocal and now AI. So the first thing to ask is on visual impression that cholangioscopy offers is what are we actually looking at and looking for? As you know, there's been a lot of work done looking at characterizing these lesions and associating these characteristics with malignant versus benign features. Most of this work, regardless of the classification system, of which there are multiple, including the Monaco and the CRM classification system, all based or use features of the surface, such as nodularity, papillary projections, and ulceration, in combination with vascular patterns. And the Mendoza, for example, has combined other criteria, CRM and Monaco, and sort of summarized them into some of the features that are most associated. And all of these studies have been based on inter-observer agreement studies, which shows, you know, pretty high sensitivities and specificities overall, but if you look at the actual inter-observer agreement of all of these studies, they are significantly high. This is the international consensus guideline, which I think just really helps summarize the features that one should be noting um, uh, when performing this exam, and actually also offer some uh, data and points that we can focus on for things like AI. These are the diagnostic accuracies of the various different classification systems. Again, keep in mind an inter-observer agreement is quite poor for all of them. And then, of course, we have confocal endomicroscopy, was one of the earlier advanced imaging modalities. It's not necessarily practiced so much anymore, but again, does offer a different way of visualizing the lesions. So this is a probe-based laser that gets placed through the cholangioscope, and fluorescein is administered. And then we look at the various patterns of fluorescein absorption, and the features that are seen to either to create criteria such as the Miami criteria, distinguish healthy from malignant, versus the Paris criteria, which actually goes further to distinguish between inflammatory versus malignant. Overall, the sensitivities uh, are not bad, but specificities were kind of poor when we didn't differentiate features too much. That improved once we kind of helped specify inflammatory versus benign versus malignant. So that leads us to AI, and its role currently in cholangioscopy. Um, as we know, it has a growing role throughout all of GI. But you can see that the area of cholangioscopy, and particularly with direct visualization and characterization, really lends itself to having a more objective method of measurement and assessment. So the current AI systems are designed to help distinguish between malignant features versus benign features. This, of course, is all based on convoluted networks that take in, millions of data points and images based on the classification systems that we currently have available. There's also heat mapping AI systems available to help distinguish malignant versus benign features. When we look at the results of these studies, you can see that the AI systems have significantly higher accuracies and sensitivities compared to both novices and experts, which again raises the question of, we know that there is a learning curve in performing cholangioscopy, but some of that learning curve isn't actually, originally we thought, in being able to characterize lesions, but in fact, if we use AI, we may do away with the need for, developing those learning curves. And that applies also to the individual features that have been associated with malignancy. Here you see significantly higher AI scores compared to the endoscopist prediction for those individual features. There are many different AI systems available. But in general, they have definitely shown that AI provides higher accuracy than conventional ERCP biopsy and brush cytology. And in addition, just overall increased accuracy compared to cholangioscopy. In this system, the AI Works cholangioscopy system that again was based on data sets from the Mendoza classification, the cholangioscopy software was found to give higher diagnostic accuracy than 25% of the participant experts and 50% of non-experts. So again, this is regardless of underlying experience. And more importantly, could be performed both real time and on previously recorded videos. So it could serve as a second opinion and potentially prevent the need for repeat ERCPs to be done in the right setting. And just to compare it to other enhanced imaging modalities, this study looked at cholangioscopy AI versus confocal, which I had previously discussed. And you can see these would be the features on cholangioscopy that would be considered malignant. These are the features on confocal, and then this is the corresponding pathology. And this study showed that there were no significant differences on the sensitivity, specificity from an AI base model versus direct visualization versus confocal, and including confocal guided biopsies, therefore suggesting that there may be a role for AI to act as a substitute, for example, for confocal, which does require time and resources. And now there have been a number of studies looking at AI. Most of them have really focused on just distinguishing benign versus malignant disease, but you can see that the accuracy rates are all above 80%, even above 90%, really promising in terms of its future in cholangioscopy and indeterminate strictures. Just to mention different techniques. So this is EUS guided cholangioscopy. Of course, therapeutic EUS, it's its own topic. But in this particular case, because of the availability of smaller cholangioscopy systems, an EUS guided procedure can be performed in the setting of a stricture that could not be cannulated by ERCP or assessed by ERCP or cholangioscopy in a retrograde fashion. So the cholangioscopy is actually inserted through the EUS scope, and again, the same characteristics can be evaluated, and as well as biopsies taken just from a different direction. It's important to comment that a lot of the value of cholangioscopy comes from ability to obtain tissue, and tissue analysis in general is an important area of where we're coming with indeterminate strictures. For example, with fish, fluorescence in situ hybridization, we can increase sensitivities above cytology in EUS FNA by applying this technology and method to those same samples that we use. We can also perform next-gen sequencing, which can help improve sensitivities and specificities as well from 42, 43% up to 85%, and can actually change management in 75% of malignant cases. Again, this is using the same tissue that we would be acquiring during a standard ERCP brush, either by brush cytology or by biopsy. Of course, cholangioscopy allows us to directly visualize the tissue that we're biopsying, and we've seen through a series of trials, many of them coming out of the Orlando group, that with as few as 3 biopsies and not requiring on-site cytology, we can get almost 100% sensitivity from these biopsies. So the better that we can target our tissue, the less resources that we need on site, and perhaps more efficient we can be with our diagnosis. So again, coming back to where we are now with guidelines, you'll see in all guidelines, but I choose the ESG guidelines because they tend to be the most sort of comprehensive and clear cut. If you do have a suspected biliary stricture and etiology is not available by imaging, there's normal LFTs, you can perform EUS if it's a distal lesion, and regardless of whether or not drainage is needed, recommended sampling is with EUS and biopsy. But in addition to that, an ERCP is recommended if drainage is needed. You can also perform cholangioscopy on that same index procedure to achieve cholangioscopy guided biopsies. If it's a perihilar lesion, EUS is certainly recommended. If drainage is needed, ERCP would also be recommended. And if it's not necessarily needed and resectable, this needs to be discussed in a multidisciplinary group as to whether or not other modalities are required to get tissue, diagnostic tissue. And then just two words on the management of biliary strictures. I'd say there's not too much that's novel about that, other than the fact that we do have more specifics on our guidelines, in that all societies are recommending a diagnosis of malignancy be confirmed before placing uncovered metal stents because of the ability to reevaluate and potentially really determine if something is benign, in which case we don't want to be placing uncovered stents and cause secondary issues. Um, and that if in the case of hilar strictures or perihilar strictures, plastic stents should actually be used first until not only is a definitive diagnosis achieved, but there is definitive patterns of drainage established so that we can make sure we're maximizing our drainage. So in terms of management, really want to make sure we're doing everything with multidisciplinary groups. For distal lesions, that we're performing all types of modalities of sampling, including US, FNA, ERCP, combined sampling methods. For proximal ones, we're going to think about performing cholangioscopy and directly visualized biopsies and place plastic stents. If there's no diagnosis, consider a short-term follow-up with repeat imaging and definitely add SPY or cholangioscopy to the armamentarium if it hasn't already been done before. And always consider some of the more rare autoimmune diseases and trialing steroids. And then just a single word on tumor ablation. PDT is something that's been around for a while. We're not really doing that too much anymore because of side effects and resource requirements, but that is the idea is basically ablation of neoplastic tissue. We can also now do radiofrequency ablation using catheters, wire-guided catheters through the stricture. And this can be done either just prior to metal stent placement or in place of that, particularly for hilar strictures, in which case we can do repeat sessions, placing plastic stents in between. So, not much new on conclusions other than really consider indeterminate strictures to be that earlier and consider performing some of these more advanced techniques on your index procedure. Thanks very much and all the best for a great course.